Well, I'm going to focus this talk on the use of a relatively new device. Maybe in the last 2 or 3 years, was a device that was typically utilized for stroke. Now they've got some catheters for management in the peripheral circulation. So it'll be the Indigo system. There you go. I didn't put a disclosure slide on it, but I'm a consultant for the company. Here you can see this is the Indigo compatibility chart. They have 4 catheters that are currently available for in the periphery. They're categorized as a Cat 3, a Cat 5, a Cat 6, and a Cat 8. Each one of those will go into a respective sheath. So the Cat 8 itself will go into a Cat 8. All the catheters themselves are straight, except for the Cat 8, which comes in 3 different sizes. You have a straight, a torque, and then an extra torque. And the catheter lengths vary based on the catheter that you're utilizing. So the Cat 3 will be the longest. It's right at 150, and the Cat 8 is right about 90 centimeters. They also have a 115, and I think the straight goes up to 135. It's a relatively straightforward catheter to use, and the aspiration system itself is quite easy to utilize. It's also quite easy to set up, and it's also quite easy to transport throughout the hospital. It's really just a direct tube that goes on the sheath itself via TUI between the 2 systems. When you take a look at the overall aspiration efficiency between the different catheters, you can see here the Cat 8 is the most powerful, so you do need to be a little bit careful when you're using it. And when you utilize it, you want to make sure that you're in clot, because if you're not in clot, you'll aspirate a fair amount of blood relatively quickly because it works so well. You can see that compared to the Cat 6 and the Cat 5, the aspiration volume is much higher, but most of those will aspirate a volume that's even greater than the angiojet itself. So I'm going to go through just a couple cases here and just give you some case examples of how it's utilized and some different techniques. So this is a first case. This is a recanalization of a tibioperineal clot. This is a patient who came in with bilateral emboli to the lower extremities from atrial fibrillation, taken off of Coumadin for a colonoscopy, and then 3 days later she presented with bilateral lower extremity ischemia. And you can see here she shuts off the right tibioperineal trunk. We admit her, we put her on heparin, and then you can see here over on the contralateral side, not the contralateral side, this is post-procedure. There was some underlying disease there. I did in this one case create a very small dissection I standard, but we had a nice result there. We then went and treated her other side here. You can see here again a clot on the contralateral leg, completely shutting off the flow right at the tibioperineal trunk. And then this is post-procedure, and this is actually sucking out the clot here in about 10 to 15 minutes. So no lytics were utilized in this case. She was a somewhat advanced age, 82, but we were able to sort of cap that lesion and take it out. This is the clot itself as we take it out. So we just want to go down there where we think the clot is, then turn on the machine. And what you really want to see is actually no blood coming through the catheter. If you see blood coming through the catheter when you're taking out a big clot, it's probably not doing its job, and you probably need to advance it a little bit more. But most people get very excited when there's a lot of blood coming through, and they think that the system's not working when there's nothing coming through. Moving it on, then on to the venous side, this is a patient who presented with Iliofemoral DBT, quite extensive DBT. This patient was actually lysed for 24 hours. You can see here post-lysis, probably the reason the clot didn't clean up that much is there's an outflow obstruction, as you can see there, through the iliofemoral segment. So instead of dripping her some more, actually went through with the Cat 8, and in about a couple passes through here, so this is, we infused her with another 10 milligrams of TPA through an infusion catheter, took the Cat 8 up. It comes with a separator as well, without a separator. Most of the time in large clot, I go without the separator and sort of just spin the catheter to help macerate it. I see what I get. If there's still clot there, when I go in the second passes, I will then use the separator to sort of clean out the distal tip. But most of the time, I go without the separator. Then we fixed her distal outflow. Now this is what we get here. This is post-procedure in the this is in the femoral segment. You'll see here that we then stented the outflow with wall stents with a very nice result. Now, having been in the thrombectomy space for quite some time, I'm never convinced that I actually remove all the clot. And sometimes I feel like maybe I just sort of made a channel through the clot. So I typically will utilize IVUS. So here you'll get a sort of a feel for what we removed. There you can see the stents coming through the iliofemoral segment. As we come into the femoral vein, that's probably right at the groin, you can see there's still a little bit of clot behind the stent, but that's probably more chronic. This is a woman's sort of femoral veins, relatively small, but you can see we've removed pretty much 90 to 100% of the clot. Now as we get down a little bit lower towards the sheath, where I didn't actually use the Cat 8 because the sheath was past the clot, you'll see still a little bit of clot right there around the sheath, and we were able to then just pull that sheath back and then suck out that remaining clot. So pretty good evidence with intravascular ultrasound demonstrating it. This is again sort of a complex problem where I think it's sort of been our go-to device. This is a patient who presented with SMA thrombosis, pretty severe abdominal pain. It's sort of a conundrum for a variety of different people. What exactly do you do with the patient? Do you drip her? Do you go do an embolectomy? And do you take out the small bowel? I'm a vascular surgeon. I'm also boarded in general surgery, but I'd rather not deal with any intestines. So I like to sort of be able to get this patient up to the cath lab. You can see here sort of an abrupt cutoff, rather distal into the SMA. Then just going up, as I spoke with Josh here, typically I will just use a pinnacle sheath. This is the 8 French, I'll use the Cat 8. But sometimes if I can't get it to track or it's tough to go around that curve, sometimes I'll use one of the deflectable catheters as well. But here you can see very nice result, relatively quick, 2 to 3 minutes to take out that clot. We'll cap it off and you can see very nice end results. So 3 minutes of total treatment time. I can't do it that quickly doing a standard embolectomy. This is just another patient right here, an acute aortic occlusion, relatively young woman, 43 years of age, smoker, had some, if you talk to her a little bit, she had sort of chronic claudication, but now she came in acutely. We went ahead and admitted her, put her on heparin. You can there see the CT scan. There's a variety of different ways to do this. This is the arteriogram. You can see relatively abrupt cutoff, approximately 2 centimeters below the renals. There's her distal runoff, so you can see I've gone percutaneous. And then again, just utilizing the Cat 8 device, crossing it. Most of the time I will utilize thrombolytics in conjunction, sort of turning it into a pharmacomechanical case. Then again, a quick 4 passes without the separator, 3 with the separator, and then went ahead and treated her, again, as it's aortic disease, I elected to treat her then with covered stents, again, based on her relatively young age. She's now follow-up of almost now 24 months, and she continues to do well with no evidence of restenosis. This is the last patient. This is sort of the dreaded complication of anyone who has to treat critical limb ischemia, but this is a thrombosed popliteal artery aneurysm presented with a CT scan there. You can see the aneurysm. He's got rest pain, he's got foot drop, and he's sort of an emergent case. Typically, we would take these patients for an operation. That operation, I feel, has got sort of a multitude of problems with it. First of all, their overall chances of survival of that leg is relatively low. The risk of amputation is quite high. So here you can see here, pre-treatment is the cutoff of the popliteal, not much in the way of collateral flow. You can see the distal runoff is quite stagnant and not much getting down to the foot. So here we actually went up through the lesion, crossed all that thrombus with a glide catheter, then actually took the Cat 8, and what you can see here is we actually created a channel through that thrombose segment, then utilizing these in a coaxial segment, utilizing the Cat 8, the Cat 6, and the Cat 3. All those will go through each other. We create a channel. Now, we're certainly not trying to get all that clot out of there, but we're going to treat that then with a Viabomb. So this is sort of the treatment algorithm, as I just stated. Did use some lytics in this case. Did this all in the cath lab, and since he already had the foot drop, I did not use any fasciotomies. Now, in a case like this, in which you're trying to remove clot, there's also this sort of distal sandpaper. This one, you'll actually see blood and sort of thrombus coming through that catheter, and you can see that over there on that right side. So it's just sort of a live case as the clot is being pulled through. Now, this was a relatively rapid case, and this is sort of the initial stuff that we removed, but sort of a relatively rapid recanalization of that popliteal. You'll see the runoff as well, but we were able to get single vessel runoff relatively quickly. Then we went in and proceeded with intervention with Viabomb stents, sizing it based on the IVUS to the very distal popliteal across the knee joint, up into the non-disease segment of the SFA. So those are the popliteal stents. But you can see flow through there is relatively slow and stagnant, and the reason for it is because I just have the single vessel runoff. We then proceeded to get another vessel runoff of the anterior tibial over there and got that. He actually did quite well, was discharged home 3 days later without fasciotomies and did relatively well. So in conclusion, the Indigo system for the periphery is a very nice endovascular option for clot management, whether it be thrombus or acute emboli. It's safe and a simple procedure, and overall reduces the need for lytics, and you can actually visualize the clot. Thank you.